Assalamualaikum and hi to our beautiful lecturer. We are from Group 6 and we will present about polymer treatment on lymphoma cancer. I am the first presenter, Nurhani Smith Abdurrahim, and let's proceed to the introduction of the study. Cancer is not a strange term anymore among us. Cancer is a disease that is caused by genetic or epigenetic changes in somatic cells, and it causes abnormal cells proliferation that can spread to other parts of the body. Global demographic profile estimates that roughly 420 million new occurrences of cancer will be diagnosed each year by 2025, implying an increase in cancer incidence over time. Cancer are classified into several categories, and one of them is lymphoma. Lymphoma is a term used to describe a class of blood disorders that arise in the lymphatic system. Basically, human's body consists of lymphocytes, a kind of normal white blood cells involved in regulation of immune system. However, white blood cells that grow without infection, trauma, or inflammation in human's body is called as lymphomas cancer. Hodgkin lymphoma, HL, or non-Hodgkin lymphoma, NHL, are the two most common kinds of all lymphoma changes disease. Cyclophosphamide, doxorubicin, vincristine, and prednisone, CHOP, has been the first option of high-intensity chemotherapy in aggressive Nhl treatment for more than 3 decades. Attempts to boost CHOP's efficacy by adding other cytotoxic medications have failed, owing to the fact that these extra drugs cannot be given until the cyclophosphamide and doxorubicin dosage are dropped below those used in the CHOP regimen. Intensified chemotherapy regimens may help young patients with a dismal prognosis, but they are not well tolerated by the elderly. CHOP, in fact, may be too toxic for older individuals. Another prevalent issue of CHOP treatment was alopecia, fatigue, taste alteration, post-chemotherapy such as nausea and exhaustion. Despite the aggressive nature of the disease, rituximab with CHOP chemotherapy can cure 50 to 70% of patients. In most cases, the failure of R-CHOP is linked to the lack of response. Primary refractoriness or relapse after achieving a complete response are the most common reasons for R-CHOP failure. Even though R-CHOP provides greater advantages to patients, it comes at a higher cost than CHOP alone, with a total cost of $16.277 for R-CHOP against $3.348 for CHOP. This study tackles objectives as follows. The first objective is to evaluate the current treatment and drugs of non-Hodgkin lymphomas. The second objective is to propose polymer replacing rituximab plus cyclophosphamide, doxorubicin, vincristine, and prednisone R-CHOP for non-Hodgkin lymphomas treatment. The third objective is to investigate the sustainable development of polymer to social and environmental. Next, I will pass to Noha Sharafana.
Hi and Assalamualaikum. My name is Nur Noha Sharafana binti Kifli with matrix number DN180065. Thank you to Ms. Hanis. Today, this disease is treating with a combination between chemotherapy with anthracycline anti-tumor drugs as the primary. Even though we know by the combination of chemotherapy able to improve the overall survival rate % of patients, however, there are still some patients that have to experience recurrence, side effects, and dose-related toxicity. The combination of CHOP and anti-CD20 antibody rituximab can improve the B-cell NHL therapeutic effects since it's accompanied with primary and secondary drug resistance. Rituximab is a chimeric monoclonal antibody targeting surface CD20 antigen that exists on normal mature B cells and virtually all B cells origin lymphoma cells. Several mechanisms lead to cell death after the cell surface opsonization by rituximab. Antibody-dependent cell cytotoxicity (ADCC) is the major effector cell, which it can be as natural killer and macrophages. Rituximab is supplied to the patients via two ways, which are through drip into the hand or arm or through the injection under the skin. By instilling rituximab, it may be injected on its own or with other cancer drugs as part of a treatment regimen. When MAB is injected into the body, it will begin to act by attaching to surface antigens, resulting in changes in immune modulation, antigen function, or in the case of antibody drug conjugates ADC, where cytotoxic is introduced into this intracellular space. Rituximab is produced by combining myeloma cells with antibody secretion cells harvested from animals. Rituximab consists of a human constant region and a murine variable region and classified into two ways with differentiation of cytotoxic mechanisms. Type 1 MAB produces strong CDC induction by creating redistribution of CD20 into lipid rafts in cell membranes, and type 2 is stronger in bringing about cell addition and cell death directly because type 2 MAB is weaker in inducing CDC and does not function through lipid rafts. Rituximab targets CD20 after injects into body. CD20 is transmembrane protein that existing on virtually all B cells. CD20 is contemplated as a pan-B cell antigenic marker, and it is not expressed in most multiple myeloma cells, corresponding to more mature B cells with plasma cell differentiation. Generally, the rituximab will bind to CD20, and thus these CD20 proteins then sticking out from the cell membrane, and rituximab that comes in Y-shaped antibodies will bind to the CD20 protein. So, CD20 can work as a calcium channel by directly activate to the calcium channel, but the signal dependent on CD20 density and the number of antibodies present. The cells can be killed via apoptic pathways, which is by rituximab-mediated cell killing. In this mechanism, TNF or FAS ligand or trail pathway will not appear since cell death is caused by CD20. This rituximab binding will decrease the IL-10 and leads to the decreasing STAT3 activation via autocrine loop, as well as cause the decreasing of BCL2 expression in EBV positive 2F7 cell line, and it is then sensitization to chemotherapy through mitochondrial pathways and induced to cell death.
I am Akila Zawani. I will continue by presenting about current scenario of formulation for NHL treatment. Basically, rituximab is administered as an intravenous IV infusion, and the technique is addressed as an intensive and uncomfortable for individuals with malignant disease that require regular basis. Currently, they are being developed with the presence of subcutaneous formulation. So, IV formulation is identified as liquid formulation that contains 10 mg per milliliter, where the excipients itself are sodium citrate, polysorbate 80, sodium chloride, hydrochloric acid, and water for the injections. So here, using the existing IV formulation, the establishing acid route of administration for rituximab was not practicable, since the amounts that required to obtain therapeutic levels is exceeded the tolerable standard. So for the manufacturing current situation for this treatment, a new dosage of rituximab of SC administration, a switch from body surface area (BSA) adjusted dosing to fixed dosing was considered to simplify drug preparation, which is ready-to-use formulation, and reducing wastage, and to reduce the potential risk of dosing errors. So here, monoclonal antibodies such as rituximab, where it is the first to be licensed for the treatment of lymphoma, NHL, offer a broad therapeutic window that allow for a new strategy where they can determine that the variability in pharmacokinetic would be no greater with a fixed dose method than a body size adjust dosing approach. So the difference in exposure were expected throughout the treated population after switching from BSA adjusted dosing with rituximab IV to a fixed dosing with rituximab SC, with a trend toward a comparatively lower exposure in patients with a high BSA and a relatively greater exposure in patients with a low BSA. So, as a result, the fixed dose of rituximab SC chosen had to be high enough to provide sufficient drug exposure across the whole BSA range. Given rituximab's broad therapeutic window, it was thought unlikely that changes in exposure expected following SC administration versus IV administration would result in a higher incidence of adverse events. Thank you, that's all from me.
Thank you to Ms. Akila. So now for innovation of rituximab is by using a technique to attach polymer to the MAB, and this technique known as antibody polymer drug conjugates APDC. The active target of hybrid polymer MAB system consists of therapeutic anti-CD20 that combine to biocompatible polymer base HPMA that bind to doxorubicin through pH-labile hydrazone bond or enzymatically cleavable oligopeptide spacer. The star-like structure of polymer MAB provides a higher drug loading capacity compared to conventional MAB. In addition, HPMA with bind-doxorubicin offers lower non-specific toxicity. HPMA polymer drug conjugates and MAB conjugates contains of high molecular weight and help them to passively assemble in solid tumors. The introduction of MAB to the targeted cell via diffusion is able to increase the accumulation rate in solid tumors and able to accelerate the tumor accumulation process, and the cytotoxic agents can be delivered to APDC by MAB active targeting into circulating malignant cells. During the blood circulation, the drugs that are bound to HPMA polymer are inactive. Besides, the release and activation of the drugs are dependent by internal stimuli such as presence of enzymes or pH changes, as well as external stimuli such as light presence within the target cells or tissues. The usage of MAB polymer conjugates is targeted to diverse tumor cells markers, and it improves the tumor resection without damaging the healthy tissues and without leaving the tumor cells. Now, we move for formulation. A quality and successful pharmaceutical formulations comes with 4 basic components. Start with benefits and constraints of active pharmaceutical ingredients, manufacturing procedure, valuable excipients, and associated interactions. For formulation of HPMA-MAB consists of several materials such as 1-aminopropane-2-ol, third-butyl carbazate, and metacryl chloride that are more safely and easily to be produced. For example, 1-aminopropane-2-ol is used as buffers and good solubilizers that is used to neutralize fatty acids and sulfonic acid-based surfactants. Besides, it is an intermediate in the synthesis of pharmaceutical drugs. The more vital is, before synthesis, all of the chemicals and solvents involved have to conduct in analytical grading, in which the solvents have to be dried and purified and also distilled before use. Firstly, HPMA should be synthesized by mixed the solution in the presence of sodium carbonate. Then, 81 to 95 yield of doxorubicin precursor can be synthesized after HPMA. The prepared doxorubicin precursor consists of BOC protected hydrazide groups in side chain and the main chain and TT group. Then it will be introduced to MI reactive group via abinolytic reaction. The hydrazide group is deprotected under optimum ratios and can be characterized via TNBSA. APDC then can be prepared using free thiol groups of monoclonal IgG antibodies, either anti-CD19 or 20 or 38. Doxorubicin precursor solution was added into phosphate buffer with argon, and MI groups will react to SH groups in MAB to generate covalent ester bonds. Then it produced polymer MAB conjugate and desalted via chromatography and lyophilized. Hence, the unreacted SH groups will be blocked by ethylene melamate addition after conjugation reaction is completed. In final step, MAB polymer will be proceeded for molecular weights and hydrodynamic size characterization via HPLC. Then, doxorubicin contents are evaluated by using UVVs. So, I will pass this to Ms. Amira.
Assalamualaikum, my name is Amira and I'll be presenting about identification of conflicting requirements in the drug's development. First of all, I start with technical issues. Rituximab is a chimeric MAB targeting CD20, a cell surface marker present on B lineage cell and consequently expressed on many B cell lymphoma subtypes. Clinical resistance to rituximab is generally defined as a lack response to a rituximab-containing treatment regimen or clinical progression after 6 months of such a regimen. Diminished response rates to rituximab in patients with prior rituximab treatments have been observed in multiple NHL subtypes. Next is engineering issue. While significant progress has been made in therapeutic antibodies, perhaps the most rapid advances have been made in non-antibody therapeutics, including the development of small molecule inhibitors that modulate key pathways important in NHL pathogenesis. The Pi3k pathway is a ubiquitous pathway involving a large number of lipid kinases that play critical roles in cell survival, proliferation, metabolism, and angiogenesis. Pi3ks are divided into 3 subclasses on the basis of structure, regulation, and lipid substrate specificity. Pi3ks often lead to activation in many cancers. Within these subclasses, several different isoforms exist, comprised of 4 different catalytic P110 subunits with variable expression observed across cell types. This variable expression has led to the development of pan-Pi3k isoform inhibitors. However, the ubiquitous expression and function of the multiple Pi3k isoforms has also led to serious concerns about significance of target toxicity. Therefore, isoform-specific inhibitors have often been explored. Regarding environment issue, I found a few factors, which is for aggressive lymphoma subtypes, the decision on therapy is based on whether patients are candidate for stem cell transplants. Those patients that are not candidates due to age, poor performance status, undergo chemotherapy with the goal of minimizing toxicity. However, prognosis is poor among these patients with expected survival of less than 1 year. Next, about safety. There are 2 main points, which are suppressed blood cell formation and other effects. Suppressed blood cell formation, decrease in blood cell counts may occur in patients treated with chemotherapy. Blood transfusions may be necessary for some patients with low blood cell counts. If decrease in white blood cell counts are severe and continue over extended periods of time, infection may develop and require antibiotic treatment. Other effects, therapy can induce extreme fatigue, fever, cough, lung function, impairment, and allergies ranging from mild to severe. Patients may also experience rashes, hair loss, weakness, nerve function impairment ranging from tingling sensations to more serious impairment of function and other effects. Lastly is regarding culture, religion. Culture plays a central role in forming the expectation of individuals about potential problems they may face with drug use. For many social groups, this may provide a protective factor. An example is the use of alcohol by the ancient Aztec before any contact with white settlers. Their use of alcohol was heavily regulated and was only for ceremonial purposes. Non-ceremonial use of alcohol was strictly forbidden under penalty of death. Initiation into excessive substance use may occur during periods of rapid social change, often among cultural groups who have had little exposure to drugs and have not developed protective normative behavior. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Husna Izzati binti Sani. My matrix is BNN40203. So now I will continue to the part of consequence of innovation. So general usage of rituximab in the relapse setting in a consequence of the facts. First, despite the facts that following failure of rituximab based on treatment, a proportions of patients may present with CD20 negative illness by conventional immunohistochemistry. Second, no effective immunotherapy other than anti-CD20 antibodies is presently licensed for the treatment of recurrent BNHL. However, certain additional CD molecules like CD19, CD22, CD38, and CD79B remain extremely intriguing candidates for enhanced BNL therapy in the future. Next, attachment of synthetic polymer precursors to the MAB result in a well-defined APDC that may be used to treat a variety of cancer. One of the PDX models was created from a patient who had previously been untreated for BNHL and served as a positive control for anti-CD20 based therapies. Direct activation of apoptosis by rituximab is inefficient unless the antibody is hypercross-linked by a secondary antibody or immobilized on plastic. The rituximab polymer was found to be much more effective in vivo against implanted radiolipomas using dosage in which the monomer and dimer preparation had little effect. The most frequently used techniques for polymer attachment to antibodies are based on the aminolytic reaction between amino groups of MAB with aminoreactive groups of synthetic polymers. The involvement of an amino groups in a MAB, whether from lysine residue or the N-terminal, frequently reduce the MAB binding ability.
As for the conclusion, DLBCL accounts 40% of all lymphoma changes disease. An innovation of MAP by using a technique to attach polymer to the MAP is the new study in overcoming the rituximab to treat lymphoma cancer. The structure of polymer MAP affords higher carried drug loading capacity as compared to ADC. The active APDC targeting with selected MAPs have high potential in enhancing the anti-lymphoma efficacy as compared to non-targeted nanotherapeutics. In terms of sustainable development, grafting polymers into the MAP structure has the potential to diminish the MAP's effectiveness and ability to adhere to the cell membrane-specific epitopes. However, attaching the polymer precursor to the tile groups of reduced antibody in a single place reduces the risk of modifying the antibody's hypervariable region. Thus, polymer MAP treatment on lymphoma cancer can be an interesting development for patients in the future. I think that's all from us. Thank you.